Well, thanks everybody, and thank you, Stanford, for putting together this wonderful conference and program. And I really appreciate the opportunity to speak with everybody today. Dr. Elsheikh and I will be presenting on multidisciplinary care in SMA. And my name is Allison Ballard, and I'm the pediatric nurse practitioner and clinical care coordinator with the Neuromuscular team at Children's Hospital, Colorado. I have no disclosures, and consents were obtained for all of the videos and audio that were used in this presentation today. First, I just want to begin by sharing with you a video of the patient's multidisciplinary care experience in the neuromuscular clinic. And as you will see, these are a few of our SMA patients and families kind of navigating their care throughout their clinic visit. So that was a lot of stuff happening in that video. And unlike the time lapse, these clinic visits take upward 3 to 4 hours per visit. So again, we have a big, large team. We have pediatric neurology, physiatry, pulmonary medicine, respiratory therapy, physical therapy, genetic counseling, nursing, dietitian, social work, and neuropsychology. We're lucky and fortunate enough to have radiology just down the hall, so that makes for ease of obtaining any imaging during and throughout their visit. Our respiratory therapist has the ability and equipment to go into each room and obtain pulmonary function data, and makes for the patients not having to go to multiple areas throughout the hospital. Also, we are lucky to have a PT gym, so it allows our therapists to attain outcome measures and do their testing. And as you can all see, we've become masters of Zoom here, and we actually created a graduation card for some of our patients and families this year. This is our clinic board. I think we all have some variation of the whiteboard in our clinics. The x-axis is the patient's names, and then the y-axis indicates the specific time. And then within each of these individual boxes, we have the care team members' initials or discipline. And when they enter into a patient's room, they mark the X that they have entered. And then upon completion of their visit, they complete that X. So we can kind of track and keep our clinic as efficient as possible. It is also a great utilization of communication. So we also put on the board if there's any imaging or labs or referrals that need to be done. Not only does it communicate with the person who's running the board, but also other team members throughout the clinic visit. It also ensures that when the patient's leaving, all of the tests have been done and communicated with the family. And this is a schedule that's placed on each person's door, each patient's door during their clinic appointment. So it provides some anticipatory guidance of their clinic visit and how things will flow that day. When the provider goes into the room, they move their sticker over to the in, and then when they're complete, they move it to the out so they can kind of see who they've seen already and who is left to be seen in their clinic appointment. It also is nice for the team members to see who's potentially in a room or if a room is open to go ahead and enter. And as my role in the multidisciplinary neuromuscular clinic, I'm the care coordinator, and my goal is to provide improved communication between patients, families, and our neuromuscular team, leading to a more efficient delivery of care through mutual goals, improving outcomes, and easing the complexities of navigating the care and management of a chronic illness. And as the care coordinator, it allows me to be that resource to centralize care across the multidisciplinary team. And my role can help bridge the gap between inpatient and outpatient care, and also provide a continuum of care between our neuromuscular clinic and schools and community-based resource programs. So in this new era of SMA and all of our recent advances, our team has expanded to include the newborn screen program. And this program is coordinated by our genetic counselor, Melissa Gibbons. And SMA was added in January of 2020, and it also includes the state of Wyoming. So as patients are diagnosed on the newborn screen, the primary care physician is notified of that diagnosis within 24 hours. And then the patient family are notified of the positive result either by the pediatrician or a genetic counselor. Within about 24 to 48 hours, they have a visit with our genetic counselor, our neuromuscular neurologist, or physiatrist to diagnose, discuss the diagnosis and treatment options. And since the start of the program, we've identified 6 patients with SMA. And then I also want to share with you an audio clip. And this is a mom whose baby was diagnosed with SMA on the newborn screen. And I think it is such a striking difference in the experience of diagnosing asymptomatic patients with SMA. And I think her words are pertinent to the care we provide across the multidisciplinary clinic. So I'll let you listen to her experience.
It was a big blow because we are from a very large family and nobody in the family has ever shown even one single sign of muscular weakness or inability to sit or walk. In my family, by 7 months, 8 months, everybody's walking. So this was a huge shock to us, and it took us time to take it in. So first, before the baby is even out, I think parents should be tested, and then they get to know that they know their status, whether they are carriers or not, so that it will not be too difficult for them to absorb it in when the final test comes for the newborn screening. So when it came, it was hard for us. It was really hard for us. Nobody in my family was willing to accept it, and especially when Jessa was showing all the signs that she was okay. She was kicking fine, she was moving, she was eating. She never deteriorated in any way. So it would be hard for any parent to take it when she's doing everything that a newborn baby does. But I think her condition started getting it started showing after her 3rd month when she was going into her 4th month. That is when she started the movement, the muscle tone started becoming weak, and then she started slowing down in her legs and other things. And that is when, um, as a parent, I became conscious of it. So probably that is why in the if you read about the previous one, they were always diagnosed around 3rd month and 4th month, because around that time, that's when you see the signs. So it was.
And then also our expanding neuromuscular team includes now the complex drug program. And this team is charged with obtaining insurance approval and coordination of all of the treatment for SMA. It is comprised of administrative support and nursing, and they work closely with our providers to authorize and deliver the treatment for patients with SMA. And this is also another audio clip of the same mom sharing her experience in terms of the discussions of treatment options for SMA. And I feel her words are very powerful and should give us all pause and when we're discussing treatment options for families and the support and the language that we use.
This was a surprise, and all I could hear was virus. And we were in COVID at that time. So I had virus, I had infection, I had liver failure. These things were ringing in my ears. So, and that is what made me put off the gene therapy, like I said. So the explanation and the information that I was really supposed to get wasn't really brought out. And when they said it was going to be in did he even say infusion? I don't think it was they mentioned infusion. My mind was like injection or injected and then he's going to. So I actually felt like it was virus and it's going to be planted. You're all the way it was described, it felt like, so when we came for the day of the therapy and I felt like it was just a normal drip that was going through her bloodstream, I was like, so this is all it is. Because the impression I had was like they were going to take part of her skin and then inject it there. Oh, yes. So we freaked out. So why would we give that to a baby? Why would I want to? Yes, for the Esperanza, it wasn't a goal for me because we were going to go for 1, 2. I can't imagine piercing her back every month or 4 months. Just for life. It didn't sit well with me. So for that I wasn't open to it. And then later on I even found out that for every injection, when you have to show that the child is even improving, so you have to also go to.
So that was a great experience for us, is sitting down with some of our families who were diagnosed on the newborn screen and learning more about their experience of their diagnosis of their child, and also discussion of the treatment options and how we as a multidisciplinary care team deliver that information. And so thank you for listening to this discussion about pediatric multidisciplinary care. And I'd like to turn it over to Dr. El-Sheikh, who will talk about the adult multidisciplinary care in SMA.
Hello, good morning, everyone. Thank you, Alison, for a nice overview of the different activities and care that in our rounded pediatric multidisciplinary care center. Thank you, everyone, and good morning again, afternoon or good evening, wherever you are. It's really my great pleasure to be here today. Thank you, Dr. Day and Stanford team for putting together this phenomenal program. I'm really honored to take part and I look forward to every part of this meeting. I am going to be providing an overview of the multidisciplinary care in an adult SMA care center. Here are my disclosures. So let me start by defining the adult SMA clinic population using the classic classification of SMA types and based on information from large databases and cohort from multidisciplinary clinics and large multi-center trials. Currently, about 2/3 of the patients in adult care clinics are SMA type 3, and about 1/3 is SMA type 2, and a small percentage is SMA type 1 and type 4. So the phenotype is somewhat different than the classic classification. And so the functional status at the time of evaluation allows for a more pragmatic approach to help guide care. So the majority of adult SMA patients will fall into one of three categories: a severe non-ambulatory phenotype, and those are non-sitters, a less severe non-ambulatory phenotype, and those are sitters, and a milder phenotype, and those are walkers. And the first group include patients previously classified as SMA type 1 and 2, and at times some type 3A. Those are essentially quadriplegic with trace distal hand movement and significant bulbar and facial involvement. They tend to have severe musculoskeletal and pulmonary complications. The second group of the non-ambulatory, the sitters, they tend to have severe leg weakness and significant proximal arm weakness. They retain movement in the distal arm, and they tend to have overall less orthopedic and pulmonary complications. Lastly, the group of the walkers, and those tend to have proximal leg more than arm weakness with no significant musculoskeletal or pulmonary complications. The multidisciplinary care for adults with SMA is based on the most recent standard of care consensus document, and it does emphasize as well the role of multidisciplinary team and a patient-centered approach. So obviously this audience needs no introduction to the diagnosis of SMA, and suffice to say this is a disease that results from SMN protein deficiency caused by deletion or mutation of the SMN1 gene with retention of at least one copy of the SMN2 gene. Most of the patients seen in the adult clinic, they usually come with established genetic diagnosis using the commercially available testing. However, occasionally we see patients carrying a diagnosis of SMA, and based on previous testing, muscle biopsy, high CK, and so on, and they turn out to have mimickers such as limb-girdle muscular dystrophy, or tend to have a non-5q proximal predominant SMA. The SMN2 copies are the main determinant of disease severity. However, in the adult clinics, there is quite an overlap, with majority of the patients having 3 to 4 copies. I would like to mention that there will be cases where there is a discrepancy between the phenotype and the SMN2 copy number, and it makes it's helpful in those situations to look for protective SMN2 gene mutation. Obviously, there are several other modifiers that are described, and probably some might make their way to the clinic in the future. So in contrast to the pediatric clinics, the focus and decision-making switch from the family to the patient, with more responsibility on the patients to play an active role, and lower tolerance overall for non-adherence. So not to forget that adult patients do develop adult diseases, and one of the or some of those patients in the clinic, they rely totally on their SMA experts without having any primary care providers. So it's so important to help them and encourage them to establish care with primary care providers so that they will get appropriate monitoring and treatment for non-SMA diseases. And obviously, not to forget that we will be hearing about the transitional care between the pediatric and the adults during this conference. So again, the emphasis is on the multidisciplinary approach, and there is a clear paradigm shift over the years in the care module and approach from a reactive type of care to a proactive and anticipatory care with ready plans for home and acute care intervention if needed. The multidisciplinary team approach usually covers the different aspects of care pertinent to the SMA individual based on all their functional abilities. Centerpiece is obviously the rehabilitation programs, physical therapy intervention to optimize function, influence disease trajectory, and as well, obviously, monitoring for therapy. So there is, you will be hearing during the conference more in depth about the physical therapy, occupational therapy, speech and language pathology approaches, and care for individuals with SMA. The new therapies that are made their way to the clinic enhance or increase the role of the clinical pharmacist and the genetic counselor as part of the team. So I'm really not going to go over details more so than just highlight that throughout this conference, we're going to be hearing about the different types of care that are pertinent to both the pediatric and adult population. Respiratory care guided by pulmonologists and respiratory therapists is pivotal and essential aspect of the care. Assessment, planning interventions, and ventilation decisions, critical care support, and immunization are few aspects of that care, and we'll be hearing more about this later in the conference. So from the gastrointestinal and nutritional care, assessment and interventions for swallowing and other gastrointestinal dysfunction, nutritional status, weight, and bone health, and we will also be hearing more about that, more details during the conference. So orthopedic care and fracture care and wound care are also highlighted by assessment and intervention for spinal and chest deformities, joint-related problems, contractures, and fractures management. So there are certain areas that are still in need for more work. So for instance, pain in SMA, although there is the epidemiological studies suggests lack of difference in pain between SMA population and the general population, the jury is still out as to the status of that in the clinic. And for now, we're using individualized approach based on the pain type, with a main focus on non-pharmacological approaches to treatment. So there are several things that surface that are of importance to patients in like adults with SMA. Those are non-motor symptoms, and in this study it highlights swallowing and lower extremity edema, falling, and nocturia. And again, an area of unmet need is really the psychological aspects and the mood disorder and its impact on overall care in the adult patient population. So another pertinent area is women's health, pregnancy, and childbirth. Several studies and reviews are out there to provide some guidance for assessment pre, during, and after childbirth, pregnancy and childbirth. Additionally, with the new therapies, there is an aspect of a need for optimal contraception and discussion of fertility risk with therapies. So the adult SMA care center in treatment era, particularly with the high-price therapies and complex insurance approval processes, really calls for a coordinated team efforts to approve, deliver, and monitor for side effects and response to treatment. This is what we use at OSU for our adult population and to monitor response to therapy and disease progression. And it is stratified based on function. This is actually is the same consensus that most of adult care centers in the US are using. Obviously, there are other outcome measures that are used as well. So there is a need for consensus on tools to monitor swallowing, bulbar function, and non-motor manifestations such as mood disorders and etc., particularly for the adult patient. I should also note that the COVID pandemic posed an additional challenge for assessment and care for patients, and it brought the virtual care to the forefront. This also emphasized the need for patient-reported outcome measures that are valid, reliable, and easily to administer. So with new therapies, there is growing need for biomarkers to help predict responsiveness to treatment and to help us individualize treatment and adjust treatment as needed to optimize therapy. This could differ based on therapies. To name a few, neurofilaments, SMN protein, electrodiagnostic studies, compound muscle action potential, motor unit number estimation using various techniques, and others such as decomposition EMG, electrical impedance myography or EIM are all entertained as options. So here are the take-home points. I think we need to encourage individuals with SMA, particularly the adults, to continue to play an active role in their care. We should emphasize the multidisciplinary care model, and there are several out there. There are the examples at the Cure SMA care centers, as well as the Muscular Dystrophy Association care centers in the US. The standard of care document should be used for guidance of optimal care, knowing it is a living document that will need periodic amendments given the advancement in the field and new therapies. Moreover, we need as an SMA community to recognize the areas of unmet need in the care model and the gaps in knowledge, particularly for the adult patient population. And we should work together to address these by rallying around collaborative research approach. I will stop here and say thank you, and please stay close to enjoy the rest of the outstanding speakers' talks. Thank you very much for having me.